We will talk about neutral zone of complete tensure. Neutral zone is that area in the mouth where during function the forces of the tongue pressing outward are neutralized by the forces of the cheeks and the lips pressing onward. This zone is referred by various names like dead space by fish, zone of minimal conflict by Matthew, and stable zone. Okay, so the forces from the tongue pressing outward are neutralized by the forces of the lips and cheeks pressing onward. These forces are developed through muscular contraction during the various functions of chewing, speaking, and swallowing. They vary in magnitude and direction in different individuals and in different periods of life. So, the way these forces are directed against the tensure will either help to stabilize them or will tend to dislodge them. Okay. Common complications of lower complete. The first complication of lower complete tensure is pain. Also, looseness being the most common complaint. Okay, so we have numerous unstable unretentive lower complete tensure. The problem is mostly present with lower complete tensure when we have a flat lower ridge. So we have unstable and unretentive lower tensure. Usually we have atrophy, mandible to more than maxilla. Mandible has less residual ridge for retention and support. Also difficulty for positioning the teeth to produce a stable tensure like that, a case of lower flat ridge. So to to create neutral zone for each patient usually indicate in case of severely atrophic mandibular ridge, high mentalis attachment, neuromuscular disease, atypical shape of oral structures, case of trauma, systemic disease. Also to locate optimal position for implants in case of partial cystectomy, and also in case of motor nerve damage to the tongue. So my aim is to improve tensure stability by constructing a denture that is shaped by muscle function and is in harmony with the surrounding oral structure. Also improve the stability and retention, and posterior teeth will be correctly positioned allowing sufficient tongue space, reduced food trapping adjacent to the molar teeth, also good aesthetic due to facial support. Anatomy is important to determine the area of neutral zone. So we have a muscle of mastication. The first muscle of mastication is the masseter muscle. Masseter muscle affects the tobaccal border of the denture. Okay, so overextension in this area will cause either irritation and soreness or dislodgement of the denture. But we have some masseter muscle has no influence, has no effect on the neutral zone. The vaccinator muscle arises from the turcomandibular raphe, from the alveolar process of the maxilla above the molars, and from the mandible below the molars. The vaccinator muscle is a horizontal muscle, and the fibers proceed anteriorly through the modulus, with some elements passing into the upper and lower lips. In the natural dentation, when the mouth is passive, the vaccinator muscle is in contact with the buccal surface of the posterior teeth and with the mucosa covering the alveolar process. In function, the vaccinator muscle contracts, the cheeks are pressed against the teeth and the alveolar process. So during mastication, the vaccinator muscle helps to place the food over the occlusal surface of the teeth in coordination with the tongue, which positions the food over the teeth from the lingual aspect. So the vaccinator muscle plays a very important role in establishing the neutral zone. Okay, we have what is common practice of centralization or localization of the occlusion. Prevent the vaccinator from performing its proper function in two ways. The first, Localization of the occlusion create a space between the cheeks and the teeth and the external surface of the tension. So food tend to accumulate in this space and it becomes more difficult for cheeks to place the food back onto the occlusal surface of the teeth. Second, the space resulting from localization prevents the maxillary from neutralizing the lateral force to the trunk of the tongue during function. This is what is called localization of occlusion, resulting in encroachment of trunk space, increasing the pressure by trunk against the lingual surface, and this resulting in instability of the tension. Okay. The first slide cross section of natural teeth showing normal teeth and tongue position, and second slide showing cross section of denture with the teeth localized, encroaching the tongue space, and forces of the tongue into the abnormal position. Also, we have different muscles of the lips, like orbicular oris muscle, canines, greater zygomatic muscle, the quadrate muscle, resurrect muscle, mentalis, triangular muscle, submuculus muscle. All these muscles affect the position of the complete denture, so affecting and stabilizing the lower complete denture and establishing the neutral zone area. So we should know that the denture should occupy a position in the mouth where all the forces during the function are neutralized. Otherwise, denture stability will be decreased proportionally to the difference in the amount of the opposing force. We should know different denture surface. We have three denture surface. The first is the impression surface, the fitting surface. Okay, the retention of denture depending on the physical means developed by adhesion and atmospheric pressure. Okay, the impression surface is only one of the three surfaces and it is important for all the three surfaces to fit as accurately as possible. Okay, the impression surface or all the retention obtained from the impression surface depending on the physical means of retention. Second surface is the occlusal surface. It's that area in contact with the teeth, either natural or artificial, of the opposite jaw. The forces developed by the muscles of mastication are received and directed by the occlusal surface to the tissues supporting and contracting the impression surface of denture. When the teeth are in contact or bullets of food is being squeezed between the teeth, the direction of force is determined by the articulating surface and the inclined planes of the teeth. Third surface is the polished or external surface. The buccal and lingual surface of the posterior teeth and the labial and lingual surface of the lower anterior teeth are not part of the occlusal surface, but are part of the polished surface of the denture. So, the more the ridge loss, the less the area of the denture base, and the less the influence of the impression surface area will have on the stability and retention of the denture. As surface area of the impression surface decreases and the external surface area increases, the development and contour of the external surface become more critical. In other words, when more of the ridge has been lost, the more the denture stability and retention is dependent on the external surface than on the impression surface. Okay, so we believe that many unstable lower denture are caused by the external surface not being properly formed and the teeth not positioned within the neutral zone. We should know the direction of forces. Okay, Dr. Fish describes the cross section of the stable denture in the molar area to be a triangle in shape, with the tooth being the apex and the denture periphery the base of the triangle. Okay, a force exerted on the inclined plane may be broken down into two components. One component acts in the direction parallel to the inclined plane, and the other component called the normal force acts perpendicularly to the inclined plane. Z. Okay, A is the direction of force, B is the normal force, and C parallel component. If the inclined plane of the external surface are properly fashioned and the forces are of equal magnitude, the resultant normal force will be in ascending direction. By the same token, if the tension are triangular but not properly located within the neutral zone, the lateral forces will be unequal and not provide the equilibrium necessary for a stable tension. So tension triangle in shape but with the D's improperly positioned within the neutral zone receive greater force from the tongue, resulting in unstable tension. This will result in either dislodgement of the tension or unequal pressure on the ridge. So we should make what is called neutralization of the forces. The lips, cheeks, and tongue in the passive and the functioning state exert forces on the natural teeth. In the natural dentation, arch integrity and the tooth position are maintained when all the forces generated by the musculature are neutralized. Any changes in the forces generated by the musculature because of increased size, altered muscle function, or abnormal habit pattern will upset the equilibrium and result in alteration of tooth position and arch force. If we accept this assumption that the teeth are positioned and maintained in a neutral state by all the forces exerted against them by the musculature, it seems reasonable that when tension are made, the artificial teeth should be placed in the same relative position to the musculature as the natural teeth. The term relative position rather than exact position is used because age, tonus of the muscle, radial resorption, and other forces and other factors may modify or alter the tension space and the neutral zone, so that the artificial teeth should not necessarily be in the exact same position as the natural teeth. So, in summary, the neutral zone philosophy is based on the concept that for each individual patient, there exists within the tension space a specific area where the function of the musculature will not unseat the tension. In other words, we should not be dogmatic and insist that the teeth should always be placed over the crest of the ridge, or lingual to the ridge, or bagal to the ridge. Placement of teeth should be dictated by the musculature and will vary for different patients. Locating the neutral zone and the planes of occlusion. Dangerous maxillary arch and the dangerous mandibular arch cases of flat ridge. We should know materials used to locate neutral zone. We can use waxes, self-cured resin. Okay. Also we can use silicone materials, and also we can use modeling compound. Okay. Modeling compound permits the patient to mold the compound into the neutral zone with the least amount of time and effort. So compound is manipulation of compound to develop the body of tension and register the neutral zone by the use of modeling compounds. There are three important factors to be considered. First, the compound must be very securely attached to the tray. So we should make loops, wire loops on the trial tension base, okay, to make mechanical means with compound to make the compound very securely attached to the tray. Second, the compound must be thoroughly and uniformly softened for the muscles to mold the material. Third, it must be hard enough so that it will not flow and will maintain its shape as the occlusion rim until inserted into the mouth for forming the neutral zone. The consistency of compound should be similar to that used when making a primer impression. So compound softened on flame. Okay, put the compound on the trial denture base and put it in the patient mouth. Correct method for rotating tray into the mouth like that. Trace it in the mouth without distorting compound rim. Okay, ask the patient to make vigorous sucking and swallowing to mold the compound rim into the neutral zone. Ask the patient to make vigorous sucking and swallowing to mold the compound rim into the neutral zone. Okay, instruct the patient to keep the lips together and swallow as if swallowing a bolus of food. Not tell the patient to close and swallow. By doing so, the patient may overdose and depress the compound into the maxillary ridge, distorting the okay. After vigorous swallowing and sucking made by the patient, okay, with the lips closed, we found the mandibular record base with the modeling plastic impression compound formed to the patient's neutral zone like that. The compound shaped according to the neutral zone of the patient. Another method to use a compound, we can make what is called occlusal pillars, have been built up in green stick to correct occlusal height. Okay, occlusal pillar to the correct occlusal height. Okay, and we can use the physical gel rim, okay, being molded within the mouth. Okay, physical gel rim being molded within. Okay, the physical gel tissue conditioner composed of powder and monomer and liquid powder polymethyl methacrylate and liquid ethyl alcohol and aromatic ester mixed in high powder to liquid ratio to get high viscosity physical gel. Okay, so the physical gel tissue conditioner can be used also to record neutral zone. After we make what is called compound pillars to can preserve the vertical dimension of the patient. So this is the physical gel tissue conditioner impression material molded for patient according to his neutral zone. Proper swallowing action will mold the compound rim into the neutral zone. Sufficient time is allowed for the compound to harden and it is then removed from the mouth and inspected. Establishing the occlusal plane. To locate the occlusal plane, place the rim back into the mouth and use a sharp pointed pencil, okay, to mark the commissures of the lips and the height of the lower lip like that. These 3 points are connected by a line that is continued on each side to a point 1/2 to 2/3 of the height of the retromolar. So make connection of the 3 anterior point, okay, and extend it posteriorly, okay, to 1/2 to 2/3 of the height of the retromolar pad. Okay, the excess compound is streamed to the line. To further check the correction of the height of the occlusal plane, observe its relationship to the lateral border of the tongue, like that. With the tongue at rest, the height of the occlusal plane should be with the greatest convexity of the lower border of the lateral border of the tongue. So check it in the patient mouth. The height of the occlusal surface of the occlusal plane should be with the greatest convexity of the lateral borders of the tongue. Testing the stability of the lower occlusal rim. The lower occlusal rim is placed back into the patient mouth and checked for stability by having the patient open wide with the lips with the tongue, count from 1 to 10, and they exaggerated O A E. If this movement raises the rim, the lack of stability must be caused by the improper molding of the compound, which was placed on a stable tray. Okay. Locating of the neutral zone for the upper arch. The molding compound is attached to the upper tray in the same manner as for the lower. It is flamed, tempered, and molded into the shape of an occlusal rim, and then is inserted into the patient's mouth with care taken to avoid contact with the cheeks and teeth. Okay, the rim is generally triangular in shape with the palatal surface sloping buccally and the buccally and downward, and the buccal surface sloping lingually and downward. The upper rim is placed back into the mouth, and usually excess compound will be seen extending below the relaxed upper lip. A line is described about 2 millimeters below the upper lip at rest, and the compound is trained to this line, like that. Excess in the posterior is cut away prior to the ridge. The upper rim is now completed and will be further modified and corrected when determining the vertical dimension and registering circulation. Fabricating of tongue, lip, and cheek matrix, what is called multi-piece cast. Great time and effort had been spent to locate the neutral zone. The compound rim indicated within it a given range where the teeth should be placed. So it is necessary and important to record or preserve the neutral zone. This is done by making matrix, multi-piece cast of the matrix of the occlusal rim, so that when the rims are removed, a space remains within the matrix, which is the neutral zone area. The matrix may be made of plaster, stone, or modeling compound. Several circular holes are made on the labial and buccal surface of the cast, and a cross is made in the tongue area of the lower mold. The same is done for the upper model and the occlusal rim. After a stone is set, the buccal and labial matrix are split into the middle to facilitate the removal of the occlusal rim. The space between the matrix represents the neutral zone and indicate where the teeth should be positioned. The matrices are useful when the trial tensure is returned to be sure that the tensure has properly filled the neutral zone. Like that, we make a circular hole on the base of the cast. Okay, different circular hole, and also on the lingual aspect and base aspect of the model. Okay, and then make stone on the lingual and parietal aspect, and also in the labial aspect, buccal aspect, and make a split anteriorly as a midline to facilitate removal of the two pieces of the matrix. Okay, this is the upper matrix after splitting at the midline, like that also. So we can remove the matrix easily, and the remaining space is the area of the neutral zone. The remaining space is the area of the neutral zone, like that. Also in the lower matrix, like that. So this is the area of the compound, okay, after recording the neutral zone, and this is the lingual plaster matrix and buccal and the labial or facial plaster matrix, and make splitting as a midline to facilitate removal of the matrix and removal of the compound, so the remaining space is the space of the neutral zone area. Okay, then pouring wax on the space to create a wax rim to facilitate arrangement of like that. So they arranged these in the neutral zone, and the matrices help to preserve the area of the neutral zone. Make try in the patient mouse. Okay, also we can use silicone impression material to record neutral zone of the lower denture. Okay, if the polish surface of a denture are generally concave, the action of the surrounding musculature is to stabilize the denture. This is of special importance in the mandibular labial region, and if this surface is convex, the lower denture will tend to displace backward and upward by the powerful labial muscle.